common questions about Parkinson's disease. What is Parkinson's disease? Parkinson's disease is a progressive neurodegenerative disorder that is pathologically defined by degeneration of the dopaminergic neurons in the substantia nigra and development of Lewy bodies in the residual dopaminergic neurons. How is Parkinson's disease diagnosed? The diagnosis of Parkinson's disease is clinical, and relies on the presence of the cardinal features of bradykinesia, rigidity, tremor, and postural instability, coupled with gradual symptom progression and a sustained response to therapy with levodopa. Is it easy or difficult to diagnose Parkinson's disease? The diagnosis of Parkinson's disease is difficult and diagnostic error is common, particularly in the early stages. Some of these features are shared by other neurologic conditions. Conditions commonly misdiagnosed as Parkinson's disease include non-Parkinsonian tremors such as essential tremor, and diseases with Parkinsonian features such as vascular Parkinsonism, progressive supranuclear palsy, and drug-induced Parkinsonism. Features that increase the likelihood of Parkinson's disease include those associated with bradykinesia. Given the inherent uncertainty of diagnosis in early disease and the increasing diagnostic accuracy with disease progression, physicians caring for patients with Parkinson's disease should periodically re-evaluate the diagnosis. Is there a role for imaging in diagnosis? Imaging plays a limited role in diagnosis and should not be used routinely. Imaging may help when the clinical presentation makes it difficult to differentiate Parkinson's disease from another disorder with similar characteristics. For example, limited quality studies indicate that magnetic resonance imaging may help differentiate the disease from progressive supranuclear palsy. Better data support using single photon emission computed tomography to distinguish the disease from essential tremor. What is the natural history of Parkinson's disease? Patients with Parkinson's disease experience progressive decline in motor and cognitive function and increased mortality. Risk factors for more rapid decline in motor function include older age at diagnosis, and prominent bradykinesia and rigidity at diagnosis. The incidence of dementia increases with patient age and duration of Parkinson's disease, with 60% of patients who have the disease developing dementia within 12 years of diagnosis. Is there a cure for Parkinson's disease? Current treatment modalities do not modify the underlying disease pathology. Instead, treatment is targeted at mitigating the symptoms of Parkinson's disease. Management can be classified into that for motor and non-motor symptoms. How are the motor symptoms managed? Motor symptoms are primarily managed with medical therapy. Physical therapy is used as an adjunct to medical therapy. Surgery is an option when medical therapy has failed. Early medical therapy. Guidelines recommend initiating treatment once patients develop functional disability. Levodopa, non-dopamine agonists, and monoamine oxidase B inhibitors can be used for initial therapy. Levodopa is administered with carbidopa, which inhibits the peripheral metabolism of levodopa, thereby allowing therapeutic concentrations of levodopa to enter the brain without disabling adverse effects. The combination of carbidopa and levodopa is the most effective agent available for the treatment of motor symptoms. However, its early use is associated with earlier development of dyskinesias. Dopamine agonists such as pramipexole and ropinirole directly stimulate dopamine receptors. They are less effective than levodopa in treating motor symptoms of Parkinson's disease, but have a lower incidence of dyskinesias. Compared with carbidopa, levodopa, dopamine agonists cause more sleepiness, edema, nausea, and hallucinations, and have higher dropout rates. Ergot-derived dopamine agonists such as capaglyn, bromocriptine, lisuride, and pergolide should not be used as first-line treatments because of the risk of serosal fibrosis and cardiac valvulopathies. If ergot-derived dopamine agonists are used, baseline and annual echocardiography chest radiography, and testing of erythrocyte sedimentation rate and renal function should be performed. Monoaminoxidase B inhibitors are less effective than either carbidopa, levodopa or dopamine agonists in treating motor symptoms of Parkinson disease, cause less dyskinesia than carbidopa, levodopa, and generate fewer adverse effects than dopamine agonists. Late medical therapy. As Parkinson disease progresses, initial therapy becomes less effective and additional motor complications develop, including dyskinesias and motor fluctuations. The patient's on time, when medication is effectively controlling the disease's symptoms, becomes shorter, and off time occurs when disease symptoms recur gradually or abruptly. These complications impair function and quality of life. Several medications are used as adjunctive therapy with levodopa to help reduce motor fluctuations. Dopamine agonists decrease off time in patients and improve function. Monoaminoxidase B inhibitors also decrease off time in patients. Catecholomethyltransferase inhibitors decrease levodopa metabolism, allowing for more levodopa to enter the brain. They also modestly decrease off time. The NMDA receptor inhibitor amantadine can be used in treatment of dyskinesias in late disease, surgery. Most patients will develop disabling symptoms despite optimal medical therapy, and are candidates for deep brain stimulation, which targets either the subthalamic nucleus or the globus pallidus interna. Risks of surgery include intracranial hemorrhage, stroke, infection, lead migration, misplacement, or fracture, and death. Physical, occupational, and speech therapy. Physical therapy improves balance, muscle strength, and walking speed in patients with Parkinson's disease. No evidence shows that one type of physical therapy is better than another. Although there is less evidence that occupational therapy is beneficial, it may help patients maintain family, social, and work roles and improve safety and motor function, and should be offered to those having difficulty performing tasks of daily living. Many patients who have the disease develop dysarthria, with low speech volume, decreased pitch, and pronunciation difficulties. Speech therapy, particularly therapy aimed at improving the volume of speech, is effective. What are the non-motor symptoms, and how are they managed? Even early in the course of Parkinson disease, non-motor symptoms such as fatigue are common. Later in the course, non-motor symptoms significantly lower patients' quality of life. Recognizing and treating these symptoms improve the quality of life for patients who have Parkinson's disease, as well as for their caregivers. Fatigue and sleep disturbance. Fatigue is present in 1/3 of patients with Parkinson disease at diagnosis, and is associated with severity of illness. It is less common in patients treated with carbidopa, levodopa. Methylphenidate may improve fatigue in patients with the disease. Excessive daytime sleepiness occurs in more than 1/2 of patients who have Parkinson disease, and is caused by both the disease itself and the adverse effects of medications, such as dopamine agonists. Movement disorders affecting sleep include rapid eye movement sleep behavior disorder, which is characterized by dramatic and potentially violent behaviors that occur during sleep, such as yelling, kicking, or jumping. Restless legs syndrome and periodic limb movement disorder. Rapid eye movement sleep behavior disorder may respond to low-dose clonazepam. Taking carbidopa, levodopa at bedtime may decrease the number of movements in patients with restless legs syndrome. Physicians should educate patients about good sleep hygiene. Physicians should advise patients with sleep attacks to refrain from hazardous activities, such as driving or operating machinery. Disorders of autonomic function. Autonomic dysfunction, evidenced by orthostatic hypertension, erectile dysfunction, urinary incontinence, and constipation, is present in most patients late in the disease. No treatments have demonstrated effectiveness in treating either orthostatic hypertension or urinary incontinence in Parkinson disease. Sildenafil may improve erectile dysfunction in patients with the disease, and polyethylene glycol may improve stool frequency and consistency. Drooling can be treated with Botox. Psychiatric disorders. Depression and psychosis occur in up to 50% of patients who have Parkinson's disease. Mild depression can be difficult to diagnose, because some of the motor symptoms of Parkinson's disease and depression overlap. Physicians should have a high index of suspicion for depression, and consider screening. When choosing an antidepressant, physicians should take into consideration comorbid conditions and the potential for drug interactions. Tricyclic antidepressants can cause anticholinergic adverse effects and should not be used in patients with cognitive impairment. Psychosis, manifested by visual or auditory hallucinations and delusions, is treated most effectively with clozapine. It requires weekly monitoring because of the risk of agranulocytosis. If regular monitoring is not possible, clozapine is modestly effective. Typical antipsychotics should be avoided because they will worsen motor symptoms. Dementia. Dementia becomes more prevalent as Parkinson's disease progresses. Clinicians should evaluate patients for other causes of dementia, and consider discontinuing anticholinergic or dopaminergic medications that may contribute to cognitive impairment. Either ivastigmine or donepezil may be used for the treatment of dementia in patients with Parkinson's disease.
Audio Jungle. Audio Jungle.